I'm Dr. Ezra Amsterdam, Distinguished Professor of Medicine and Associate Chief for Academic Affairs of the Division of Cardiovascular Medicine at the University of California, Davis School of Medicine and Medical Center in Sacramento, California. It's a pleasure to be here at another one of these fantastic meetings, and I'm going to tell you a little bit about my focus at this meeting. I've been interested for over 2 decades in the low-risk patient that presents to the emergency department with chest pain. They comprise the largest proportion of all patients that come to the ED with chest pain. Of course, we're very concerned about STEMIs, but they're less than 4%, less than 5%, 3 to 4% of all chest pain patients that come to the ER. That's the ST elevation myocardial infarction. Non-STEMIs are also a large group, about 40% perhaps of all acute coronary syndromes that come to the emergency room with the chief complaint of chest pain. Now you can see then that the largest group, the majority, perhaps 60% or more, are patients who come with chest pain but do not have a life-threatening problem. And many of these people require only a minimal evaluation to exclude acute coronary syndrome so they can be discharged from the emergency room. The problem, challenge posed by these patients is that they are very numerous, 8 to 10 million visits a year in the United States alone. They require an abundant proportion of resources and person power from the institution to ensure the safety of a prompt discharge. Because not all institutions follow what we call an accelerated diagnostic protocol for these patients, some stay 24 hours or more, again emphasizing the huge output in resources for these patients. Part of the reluctance to apply and implement an accelerated diagnostic protocol is the safety concern for the patient. We know that some myocardial infarctions present with a normal electrocardiogram, and injury markers are not always reliable, although they are becoming more so with troponin and high sensitivity troponin. We have been able in the last several decades to implement an accelerated diagnostic protocol that involves the assurance that the patient is clinically stable, has a series of normal electrocardiograms over several hours, continues to be clinically stable, and has several troponin evaluation measurements done over 3 to 6 hours. In many cases, we employ a functional test to further ensure the safety of an early discharge. And that functional test in our hands has been exercise treadmill testing. About 1/3 of our patients cannot exercise for a variety of reasons. And so we utilize stress imaging, pharmacologic stress imaging, usually with myocardial scintigraphy. Many institutions use myocardial scintigraphy as their test of choice to begin with, or a stress echocardiogram. And computed tomography, coronary angiography has risen in the last 10 years to ensure normal coronary anatomy, which also will increase the safety of early discharge. So all of those methods are utilized. Of late, we have been employing an even more simple procedure, and that is patient stability, serial markers, serial electrocardiograms, and then discharge within 6 to 10 hours, which is extremely rapid and actually more rapid than is accomplished with CT coronary angiography, which claims to be the fastest in terms of a safe protocol. We have done this simple procedure in over 1,000 patients with approaching 100% safety at 30 days, no cardiac events. We have had one cardiac event, so approaches 100%. But that was 4 years ago, and we have not had a single cardiac event within 30 days of instituting the simpler protocol without a functional cardiac test. So this has enabled us to provide safe discharge for patients and excluding an acute coronary syndrome, who can then be further evaluated as outpatients by their own physicians or cardiologists if being referred to a cardiologist. This has first ensured patient safety and second ensured the lowest liability, which is also a great concern of the institution if it misses an acute coronary syndrome. This has been very successful, and I've just given you somewhat of an evolution of the way management of the low-risk patient coming to the emergency department with chest pain has evolved. Simpler procedures, less testing, testing at physician discretion beyond ECGs and troponins. This is still a work in progress. A variety of methods and approaches are employed for this huge number of patients at institutions in the United States and around the world. And we will see continuing progress, I think, in efficient, safe, cost-effective management of these patients.